from Apollo Hyderguda, India. And today's gentleman is a 49-year-old man who, after an old inferior wall MI, had
Hello?
a.
Maybe
Oh,
I think they are live.
yeah. Uh, can you hear me?
So I think this is a case presentation.
Yeah,
It's
yes,
a case
yes. We're
presentation.
talking about a 49-year-old gentleman this morning who sustained an old inferior wall MI and was found to have a single vessel disease involving his RCA. He then subsequently underwent a PCI with
Okay,
DES
so I can make the presentation, but
to
everyone can read. 49 years old
yes.
Indeed.
Can you hear me?
in cabbage, I think.
Yes, he is a diabetic hypertensive with fair LV function and a normal
Okay, next one.
creatinine. Can I have the next slide, please? Okay, this is a RAO caudal view. We find the LMCA is
Okay,
pristinely
so
normal.
I think it's the RCA occlusion.
Yes, it is a 100% occlusion of an ISR nature. So we have a CTO ISR with a long segment occlusion. Next, please.
Okay, next.
And what you can see is some distal septal collaterals to the
Very
PDA.
beautiful collaterals from the septal.
To the PDA. And next, here is the RA cranial view, which again shows you distinct septal collaterals from the LAD to
Okay,
the
next.
PDA. Next, this is an LAO cranial view, again showing the same. Next, and this is
So
the
the-
RCA CTO. So there is a
okay.
proximal tight lesion with a significant mid-segment CTO. And this is an ambiguous cap with bifurcation of the RV branch and a long segment CTO, which qualifies it as a approximately a JCTO score of 2. Next. Next. And so with that, I'm going to hand over to Dr. Suryaprakash, who is our mentor and leads the CTO.
Okay, good afternoon. First of all, my gratitude to Dr. Tamam and the IMC organizers for giving us this opportunity. And here it's a festival days here. In spite of that, all my team members and the staff assembled for the CTO live demonstration case here. First of all, my thanks to the patient who has got a patient to stay on the bed for almost 3 hours. And to my left, Dr. Kapardhi, Dr. Vishwanath, Dr. Shah, Dr. Satyajit, Dr. Kapil, and Dr. Narayan Rao. And my right, Dr. Mr. Bharati and Lakshmi Narayana and Madhu and Prudhvi and Padma, all staff, excellent coordination in the team. So this gentleman, as I said, I will start the case. As you know, this is a long segment ISR and ambiguous cap, and so we had a good retrograde collateral, which we have seen in the ariocaudal and the ariocranial view. One of the septal appears good. So my primary approach in this case, I preferred a retrograde. I want your opinion in this.
Okay, so I think first you may have a very huge cat lab because you have all these people behind you. I think it's incredible. Huh? So thank you so much being with us. So we saw the diagnostic angio, and so it's instant occlusion.
Yeah.
And
Instant CTO.
the stent is going close to the crux, or because it's I'm not sure.
Exactly.
Beyond bifurcation.
Just beyond the bifurcation.
Okay.
Just beyond the bifurcation. We lost the PLV in the ISR, which is retrogradely filling from the left system. The PD, just beyond the bifurcation, PD is filling.
Okay, so
So what is the strategy? Can I know the strategy of chairpersons and discussants? How is your approach?
So what is your sitting was 7 French, I saw, femoral approach?
Yeah, 7 French only. Actually, here our intended strategy here is a retrograde primary approach with some anti-grade preparation.
Good.
But right side actually 7 French ampoulage catheter we have taken, and left side extra backup 7 French catheter for left coronary system. So we found some variations when we are approaching by step by step.
Now we have got this Corsair 150 and the septal collateral. We entered the septal collateral with the Cyan, and after entering it, the Corsair selective injection we have given. Selective injection we have given. Next please.
He wants to go retrograde, so
Please show. Next selective injection. This is a selective septal joining the PD. Joining the PD.
Starting retrograde.
So we preferred a CO wire here because a lot of tortuosity here.
So everyone will go anti-grade first, okay?
Anti-grade, because this case, you see retrospectively what happened, I will tell you. So this is a tortuous collateral we could cross easily with a CO. Next.
Assessed by the angio if we have contrast inside the stent, because in that setting we can discuss
but it's a very pretty long segment, more than 35 millimeter occlusion with a lot of hard tissue here. So we could enter the wire CO wire there, but we exchanged it to a Gaia 1 for the distal penetration. But Gaia 1, Gaia 2, Gaia 3 also could not penetrate the tissue.
The major risk to lose the RV branch, because then it goes via septal, so he's in PDA. Then so, wires going up inside the stent.
Inside the stent. We checked in RAO view and LAO view mostly, and once I find the lateral view also very good in RCA CTOs. Here we preferred all three views. But the Corsair negotiating is impossible even with a good backup of the EBU catheter. It's a very tough tissue, and I could not enter the tissue. So we struggled quite a lot for 1 hour not to able to cross the tissue, very hard tissue there. So then the anti-grade bed preparation has been done. Corsair with, you go to Corsair 135 with a Gaia 1 we preferred. And we want to do a reverse cut, but one of the techniques I usually follow, if I feel in the instant restenosis, if I am the track, I quite often do a Rendezvous technique, which I tried in this case. But finally, a Gaia 3 could cross the antigrade. Almost we tried a Rendezvous technique, but we could not succeed. Then finally, with a selective injection, retrograde injection with the Corsair. Next. So this injection showed we are in the true lumen. So I could cross with the Gaia 3 finally. But I don't want to keep the Gaia 3 there. So next, we had a balloon trap and exchanged, and we have done a 1 millimeter. Sapphire balloon could not go, 1.25 could not go, Reservin, and finally Tazuna 1.25 who could cross and dilate the lesions. And serial balloons have been done with 2 millimeter, 2.5, and after that we want to know the pathology. You give the injection of the Corsair injection. Show the Corsair injection before.
Exchange.
Please show the Corsair injection. We are in the true lumen. This shows the true lumen. So once we are sure, we extended the wire to a Cyan wire. I don't want to keep the Gaia 3 at the distal because of the risk of perforation, and we removed the Corsair. So here, after serial balloon dilatations, we have done a OCT. You can show. You explain. We have done a OCT with a optis.
OCT has a very interesting findings. So distally, there is some edge flaps are there, just distal to the stent. Then in the distal and mid segment of the CTO, yes, next. There is yes, there's some dissection planes are also there which are tried through distal crossing. Here you can say hyperintense signals indicating neo-intimal hyperplasia in the mid segment, where we find difficulty in wire penetration in the mid segment of the ISR CTO. Then if you can come to the proximal segment, you can see the proximal segment. It is a heterogeneous tissue indicating a lot of lipid pools along with smooth muscle hyperplasia, and neo-intimal channels also we can see. Some small micro channels will be seen, neo-intimal channels we can see. So this is a very interesting OCT findings of ISR CTO. If you can dig out the literature are showing ISR CTO of OCT is you can see now the fine micro channels in the neo-intimal tissue with a heterogeneous lipid pools. So there are three types of pathological findings in ISR CTO by OCT. The one is neo-intimal hyperplasia, which is a uniform hyperintense signals, which is a smooth muscle proliferative tissue. Whereas second variety is a heterogeneous type of signal intensity, admixture of lipid pool signals as well as neo-intimal hyperplasia. So these are the things which was beautifully demonstrated in this present case on the OCT. Then the next steps will take care by...
Actually, the distal dissection on the OCT in the PD has been covered with a 2.5 stent. That's what we have done here. We covered with the 2.5 with the overlap with the proximal segment of the distal stent. And after that, the flow is established in the PDA. Next. Now, our strategy is to do a drug-electric balloon, DEB. We got here a magic touch balloon, a sirolimus balloon, which we quite often use here. We got the distal stent is around 3. There are 3 stents here. The distal one is 3 into 37, a long time, 3 years back. Put this stent. So we are doing a DEB with a 3 into 40 balloon for the distal segment. What is your strategy in this ISR CTO? Really hard CTO, there is no doubt.
Yes,
It took a lot of radiation for us and some contrast also.
Okay. So just one question. May we have a retrograde injection to see if there is a RV branch?
You want a RV branch?
Yeah, because it seems that you lose this branch, no?
No, this
PLV
is not there
branch,
from the
PLV
beginning.
branch.
This is not there from the beginning. We got only the PLV branch, which is filling retrogradely. That if you want to, we can open it with a crusade catheter, but I don't feel which is filling retrogradely. So this one you can. This is a 3 into 40 DAB. It's a nominal pressure of this is around 6, 8. You can go. 30 seconds.
So
they
finally,
describe.
Hello.
Any queries?
Hello. Cut off. Intermittent disruption is there.
Are you able to hear?
Alexander,
Yes.
would
please,
you ask them for?
please.
I think you are absolutely right. There is some staining on the PLV.
Yes.
There is a PLV is closed in the ISR, but it is retrogradely filling from the left system. So whether we should open it antigrade with a crusade is another step. We will discuss that.
Yeah.
This
But
balloon we have to inflate 2 times at 6 nominal and 30 seconds each time for the drug delivery of sirolimus.
But could you, in this timing, show us a retrograde, please?
We will
Retrograde
injection.
injection.
We will deflate the. Once it deflates, I will give the retrograde injection.
You can do RO
Show to
cranial.
RO
You can do
cranial.
RO cranial. RO cranial. Now you can. There is the disappearing of collateral connecting to the PDA, and PLV is filling. You can see
PLV is
beautifully. The
filling.
PLV is filling through epicardial collateral.
So you can see that you have RV branch.
RV branch.
Maybe you have to go left cranial, then you can
Okay.
maybe.
Go to left cranial.
Allocrane.
Integrating. Yeah, retrograde. Once retrograding gets.
You can see PLV is filling.
PLV is filling
Okay.
through
You
the
see, it's not.
ISR. We can do a open of the PLV, not a issue with the studs. So now we are doing the 3.5 balloon for the proximal part of the stent, which is a 3.5 stent. So we are doing for the ISR a DAB of 3.5 into 40.
Okay. So what will be in the room your strategy here?
PLV.
Yeah.
Asking.
For the PLV, as I will open
Yes.
with a crusade catheter.
You need to open the
Yes, yes.
posterolateral branch.
Absolutely.
Yeah.
So I think they do microcatheter.
Taking
and,
crusade.
is,
Crusade and to enter
With
the
double
wide to
lumen
PLV.
catheter, I will open in the
Crusade.
PDA and go with the
integrate.
crossing the.
and
Yes.
Give the balloon
So we just
3.5.
be very short. Can cross with walk Osgard wire.
Okay.
So, we can cross with
Sian
something
will
like Sian with a double lumen catheter.
I think from the very beginning, would you have approached it differently? I mean, we have excellent retrograde collaterals to the PDA. And what I would have done is invest some time going antegradely into the PLA. And that way, if we end up losing the PDA, we have two options: either get it antegradely with the dual lumen microcatheter or via those septal perforators. But losing the
And
PLA at this
now
stage,
also it is
layer-
ISR PLV already closed through the. Now to the stats we
Catheter.
can enter it, not a
Really.
problem.
very body collateral going into the PLA. So perhaps
Great.
securing it first antegradely would have been a safer option.
Yeah. The
Now it is
strategy-
retrogradely filling, so there is no acute issue for him.
You know, one question here is how
Yeah.
much contrast and radiation have you
It
used so
is,
far? Because I agree with you.
It is
Like
almost
7 gray.
280 ml.
Yes.
Visipac.
So
So Dr. Rao, how
Please.
contrast volume? It would be interesting to
280
know.
ml Visipac. we use.
Contrast volume is around 280 ml of
Visipac.
contrast.
very good.
Are you happy with that? You feel it is more for this long case and a hybrid approach we
Yeah.
had.
But so, what will be your strategy for the posterolateral branch?
I will
we are-
do a dual lumen catheter and open the PLV. Not an issue. Maybe
Okay.
a plain balloon dilatation of the vessel will do first. So it is filling actually nicely from the other collateral from
Epicardial
the left
collateral.
system. But even then, as you said, we have to open it. 38. Go on to open. So any
No, we have to-
inquiries of this case? Anything? Any discussion further?
We are taking.
But
No, we are taking.
The decision is to use a dual lumen microcatheter
Yeah,
to open the
Ah.
P
Now we are
branch,
ta-
and then which wire you will use to cross.
Alexander, can we also learn the amount of radiation and the
Yes.
contrast?
He already told us.
Yes, I
200
agree.
on
Yes, I agree.
CC.
We crossed the
and
limit. No doubt. We
But it's
but here you used what is
Rat-
this? No,
Or
it is
stammer.
not rat pad. This is a scatter.
Scatter stomach.
Scatter rad we are using. It's a bismuth antimony combination, and most of the
you
CTO
can see
cases we
actually.
use this
Which will protect from radiation actually.
scatter radiation.
Scatter armor.
Anti-rad.
Okay, it is a radiation shield.
Okay, so to
radiation shield.
protect the patient.
Yeah, for every CTO case we use this one.
Okay, so which double lumen microcatheter will you use now?
Go to RO
We are using Crusade only.
Crusade only.
Crusade we are
We
using.
got a
Yeah, yeah, yeah.
Sasuke also available, but we right in the lab we integrate here.
Okay.
Yeah.
So that's PD, and as you said, we'll go for the
Crusade.
PLV also with the Crusade.
Crusade and Sian will take
Crusade. Come to LA.
Okay, so
to protect the PLV.
So I'm coming out from the left system. I will give an injection on the left, and if you are happy with the collateral, no collateral damage as a protocol, retrograde injection. So I check the retrograde collaterals and take out the systems there. So absolutely no damage to the collateral, and the left main is clean and the systems are okay. So go to the same view, Babu. I am pulling out the left system, it's which I think is unnecessary. The ACT is maintained above 300 and all the time. Okay. So we take a Crusade catheter. Time permits, we'll enter the LAO, please. Crusade with Cian, antigrade.
and what would be your wire inside the Crusade?
Already this is a Cian. This is a Cian is there.
Yeah, but
Under Sian.
So we'll
the
put
one you
under
will
Cian.
to cross the posterolateral branch. What will be your?
I prefer a Cian wire. I will see. I go to the areocranial. How much the length of the wire?
So what wire are you using here in the? Yes. The mic. Here. Yeah.
Settle. Yeah.
Okay. Go to the LAO. LAO cranial.
But
LAO
he
cranial.
used only all through, or he put stents?
No, he put stents.
I have
In
put
the
one
distal
stent.
part, there,
There is a
will
dissection in the
decide to-
OCT, so I have put a stent there.
Just near the
at the origin of
Yeah, there is 2 layers now.
There's 2 layers now.
I think.
confirm this issue.
He had 3 stents.
So what would be your choice for the wire to cross?
Cian,
I
Cian.
would Bunkers Pro, maybe.
For the
So
PLV,
we will look for the wire.
why stiff wire for crossing a side branch?
Nobody on a stiff wire.
Why
Nobody?
I don't need a stiff wire for that?
Intermediate wire.
Okay, take the wire.
Yeah.
So
Cian
do you
wire.
think he will succeed to cross?
Hopefully we
Yes.
will do that.
Sian this.
Who think he will succeed? A few, huh? So you are not optimistic, yeah?
Normally in this situation, I like start with the ultimate bros tree.
Yes.
This is very wire with the dual lumen crossing side branch. Is a intermediate stiffness, a good control, and I think that's much better than a stiffer wire that can go outside. Can cause perforation. And I think that very soft wire in this case they are not so useful because they prolapse. They cannot penetrate in the osteo of the posterolateral branch.
Okay.
Another point is because the main branch is a stent, we can also use a market because sometimes the angulation with the double lumen can be difficult to manage to place the wire in a side branch.
So actually you are using a Sion wire, yes?
Sian, yeah, soft wire.
Yes, yes. I'll make a more bend in the wire.
A Sion.
Sian.
Which one? Sion blue, Sion regular
Plain,
one, Sion black?
Cyan regular only.
Regular.
Regular one.
Fantastic, no? Bend. చిన్న ఇంజెక్షన్ ఎక్కడ నుంచి స్మాల్ బ్యాండేజ్. దిస్ ఈజ్ యాంటీగ్రేట్ ఇదే కదా. ఐ విల్ గివ్ ఇంజెక్షన్ అండ్ సీ.
Yeah.
Okay.
Now you can enter.
Still lot of ISR is there.
Field text కొంచెం బెల్ పెట్టాము.
Whisper also is a good wire. I will try even Whisper also. Give me Whisper.
Alex.
ಅದು 3.5 30 dilate ಇದೆ ಅಂತ below can see
3.5 the dilation.
flow
After opening this one, I can which
So
way
you modified curve of the Sayon, huh?
Yeah.
tip I
Tip.
modified. Then if not, I will try to do with a Whisper also.
next time. Yeah. And same it went.
So I think Alex, the uh,
ఫీల్డర్ తీసుకుంటారు అది ఫీల్డర్ ఎక్స్ట్రా తీసుకుంటారు.
Alex,
Yes.
yeah, I think we have a great learning
Yes.
case
Always.
here. I think first of all, this is at the previous
no,
stint.
it went. It went.
So we have a previous angiogram.
Yes.
So we should have seen that previous angiogram.
Sure.
So we know really how the distal looks and what was the end result before, and so we know and we plan. So proper planning for the case is the key to success. And remember, my teacher always told me that you have to have plan A, plan B, prepare the case well, and this is where we really has made maybe we have not seen the distal properly before we started putting another stent, where we made our life now more complicated. But this is a good learning case because we learn from these cases.
Yes.
And this is why we are presenting these. But even if you cross with the wire, it will be a challenge to cross with the balloon. A two double stent layer.
It's a double laid. That's the problem.
Very, very challenging to cross. And then you think of the long-term result as well. And you think of the left system is quite good. And I hope that it has a study before, look for ischemia. So we are doing this, all this, we're doing it for a good reason.
Yes, perfect. I absolutely agree with you, with your comment. Say we have
I
Give
think
me
the
the
main issue
Whisper.
layers of the
ACT చూసారా?
I think
తీసుకోండి.
What is ACT?
so, what about the opinion that this branch or get a flow, good flow from retrograde from
That's
left
what
system?
I am feeling.
Can we-
I say good retrograde flow is there. Why to
again
disturb
ask
that?
the question. There was also a very good flow from retrograde to
Retrograde,
PDA
PDA
first. So
also,
why
yeah.
to
But I have to do this in the live to open the C2 ISR. Important.
So how long did you try with this wire
And I will try
switch
to
for
I whisper wire. I will whisper. You
Yeah.
feel such type to two layers of
Wire.
strands to cross
Regarding
ideal wire is
wire.
ultimate boss or fielder XT?
Yes. And the Scion, we know it is an untapered, the whole Scion family. So I think with an untapered the wire, it is very difficult to cross two struts. First, the choice should be a tapered wire, like the XT or even a Gaia.
Okay.
Second, we should choose a hydrophilic
Yeah.
tipped wire.
This is a hydrophilic
Like-
wire. What I took is a whisper.
I-
It's a hydrophilic.
I'm not sure whether a polymeric coat would be useful. because I
3.5
think
NC balloon will dilate, sir,
these
everything.
caps are softer.
బిల్డప్ పూర్తి చేద్దాం నెక్స్ట్ అది టు ఓపెన్ ద స్టడ్ సైజ్
Hence, I think the coat will be damaged with torqueability.
Okay.
So I mean, in this case, we need the trackable
ఇట్ వెంట్ నౌ ఫిల్టర్
Okay.
XTR వెంట్
Yes,
Oh.
but
ఫిల్టర్ XTR
So you
వెంట్
cross.
I cross.
యా ఫిల్టర్ XTR
feeder XTR.
No,
Yeah,
no,
yeah,
it is it is a
whisper
wire.
whisper
I'm
sorry whisper
This is the
hydrophilic
whisper.
coated
No.
This is the whisper wire.
yeah
Whisper
whisper
wire.
whisper
I remove
These-
whisper.
No?
whisper which
Can-
is hydrophilic coated
Can you the wire you took?
whisper
Ah,
which is-
whisper.
hydrophilic coated
Can we have a retrograde injection to assess the distal?
hydrophilic
Hold on, దీన్ని డిపెండ్ కాకుండా
took ఇంజెక్షన్ ఫస్ట్ కన్ఫర్మ్ ద పొజిషన్
చేద్దామండి ఫస్ట్ ఇది రాని ఉంది సార్ బయటికి అది అక్కడే ఉంటుంది ఏం కాదు మీరు ఇది ఓపెన్ చేయి ఓపెన్ విషయం కోఆర్డినేషన్ కావాలి ఇది తీయాలి కదా ఓకే ఇది అది ఓకే నౌ retrograde ఇంజెక్షన్ ప్లీజ్
Yes,
retrograde
perfect.
retrograde will
ఇది retrograde సిస్టర్ ఇది retrograde దిస్ ఈజ్ retrograde తీసుకో బాబు retrograde ఇంజెక్షన్ ఇన్ విచ్ we want to give
same view we can confirm the
ఎంగేజ్ చేయాలి గైడింగ్ ఎంగేజ్ ఎలివో ప్లీజ్ ఆస్పెక్ట్ దిస్ ఓకే ఇదేనా ఓకే ఏసీటీ చెక్ చేస్తున్నారు
please check Cine.
ఎస్
yeah it is in that position
ఈజ్ ఇన్ ద పిఎల్బి
Yeah, perfect.
So I will dilate with a 1.5 balloon and see the studs. ఇదేంటిది I will remove the crusade. అదే బెలూన్ ఇచ్చారా ఇంకోటి ఇవ్వండి So now I think as you said the hydrophilic wire is a better choice. As you said it can be a polymer jacket with hydrophilic or a whisper which is our favorite wire in most of the complex lesions, workhorse wire. So we use that. But as you said,
So now Crusade,
we'll
Oh, yeah,
remove the
remove the
crusade
crusade now.
with a balloon
Crusade.
trap.
Manjo. I don't know what name you have in your country. Is Crusade again?
Crusade only.
Crusade
Or-
only.
Actually, we got a Sasuke also available with us.
Oh, sorry, yes. Yeah, but Sasuke is a new one from Asahi.
New one from Asahi.
Crusade is an old one.
Old
hold
one.
on Kaneka Crusaders
Absolutely. So now it's in France. It's from Terumo.
Okay,
right, right.
okay.
okay
పుష్ చేస్తూ తీయాలి
now we are removing the crusade
కాదు, మీరు
catheter
help చేయాలి ఇది పుష్ చేస్తూ తీయాలి వైరు సెంటర్ లూమ్ ఏంది పుష్ చేస్తూ ఓపెన్ చేయండి అది సెంటర్ లూమ్ ఏంది పుష్ చేస్తూ తీయాలి అయితే వచ్చేస్తుంది
తీసే
బెలూన్ డీఫ్లేట్ అలాగా పైకి రాగాలి సెట్ డీఫ్లేట్ చేయి పైకి లావు ఓకే ఓపెన్ చేయండి బెలూన్ డీప్లీ ఇన్ఫ్లేట్ చేయాలి రావట్లేదండి
వైరస్
వైర్ వచ్చేస్తుంది దాంట్లో ఇన్ఫ్లేట్ చేసి ఉంచు
బస్ యా ఓకే
ఇదే కదా సెంటర్లో మీద రావాలి అంతేనా
అంతే సార్ యా మనకి
ఉండండి
కొంచెం వెనక్కి వెళ్ళండి
ఒక్క నిమిషం ఉండండి
Uh,
సార్.
it, yes, no both.
ఇంకా రాలేదు.
Which is now we
Okay.
removed the crusade. Now we are dilating the ostium of the PLV. This one, sir. Different. You deflect it. Yeah. Remove it.
ఈ వైరస్ విస్పర్ మీద
2 mm
ఇది
balloon
ఇవ్వండి నాకు.
వెళ్ళిపోతుంది, sir. 2 mm
టార్కర్
balloon
ఇవ్వండి.
we can take. 2 mm balloon.
విస్పర్ వైర్ ఇది. విస్పర్ వైర్ మీ టార్కర్ పెట్టి. అండ్ 3తో ఒక 3.5 బెలూన్తో మొత్తం స్టిచ్ చేద్దాం సార్. ఐఎస్ఆర్ చాలా ఉంది.
Kissing, final kissing we can do. First dilate the PLV.
అది ఇంజెక్షన్
So now you plan to use a balloon.
Yeah, balloon dilatation for PLV ostium.
Which one?
But,
ఓకే
balloon, what is a balloon?
తీసుకోండి బెలూన్ ఎనీథింగ్
1.25
1.25 టేక్.
Tajuna.
This is
1.5 mm
this.
balloon Tajuna. Yes, you can take.
Okay.
తీసి చేద్దాం. 3.5 డక్తో చేసాం కదా, మళ్ళీ ఇక్కడ చేద్దాం. సార్ వస్తుంది సార్, మనం ఏం చేయలేం దానికి.
So everybody is confident about the crossing of the balloon, 1.5.
We are, so far we are optimistic for this tough case, so hopefully
Actually,
fine.
very for difficult lesions, tough lesions, Tajuna usually crosses the this type of side branch ostium we have seen. So now we are confident.
చాలు. ACT is 319. We are monitoring every half an hour.
Yeah. వెళ్ళింది కదా. అబ్బా నిజంగానే.
Yes.
No.
Yes, we had difficulty.
ముందు no, first winning you have to. White
We
wine.
take
White
this
wine.
here.
White wine first you have to. This one.
ఇదేనా?
Slightly.
Okay.
No, you can
Okay,
go
now
ahead.
I'll
No, you
try.
can go ahead. Yeah.
No. As you said, it is tough. The balloon going there. Take 1 millimeter. Take 1
Well,
millimeter.
what is the length? Balloon is a 15.
This is only 10.
10 mm. 10 mm.
10
10 mm.
millimeter.
10 mm length. 10
How
mm.
long?
10
10
millimeter.
millimeters length. Yeah.
Okay.
We'll take a sapphire 1 millimeter. There.
So if someone has some help to the operator here, the balloon is not crossing. Why? Maybe because wire get outside some strut.
No, it is inside. We
Inside.
removed it
Support.
through the
You
retrograde
can use
injection.
PDA branch to anchor a balloon, and then
it
maybe
needs,
more support.
because of the alignment, the wire is going from the outer margin of the stent. That's why it has made a angle, and there are a couple of layers of stents. That's why the balloon is difficult.
This is 1 into 10 mm.
But I don't want to try hard on this because the PLV is feeling quite retrograde and.
Now we are taking 1 mm into 10 mm, 1 into 10 mm balloon. No, it went. Difficult to cross.
It is a difficult cross.
Yeah.
What do you feel? We should
Done.
try hard for this?
Yes.
Which paper?
So this is the same balloon.
No,
No,
this
no.
is sapphire 1 millimeter, lowest profile,
Lowest profile, 1
available
mm.
with us.
So sapphire 1 millimeter. Okay.
Yeah.
1
But
millimeter.
difficult to cross.
But just inflate the balloon little bit. There's another
be
technique
careful your
we
gate.
use.
Careful.
Then we'll push little, keep off inflated 3-4 atmospheres. Then I'll push the balloon. Sometimes that will work out.
Difficult.
So it's a very hard
Gliding
calcific
catheter is coming over.
lesion, multiple layers of stents. I think if it is retrogradely filling, I'm happy with that.
So do you have Another solution?
What?
So
Yeah.
Going back to PDA and post dilate with a larger balloon.
They did already. They did before.
we have done
We
it.
did already.
Now I'll give a final injection here, antigrade injection.
No, okay.
You can use 0.6.
Antigrade.
3.5 you can dilate it so that it will open.
But Sapphire 1.0 is a good one.
Good one.
Yeah,
Iris. But Iris will not help for the crossing.
2 steps.
Please. Too many studs are there. Fill that.
So
above.
it's too.
Post delay,
You
yeah.
can perform a pot
Yes.
rotation in
So
just
you
before
take
the
a
carina
3.5 balloon. I'm not much worried about the PLV, which is nicely filling from the retrograde. I will just settle the issue of ISR in the main
layer.
this thing with a little high pressure dilatation with a higher size balloon. That's more important for me, I think. Is it PLV? Whisper wire,
3.5 తీసుకున్నాం. Whisper వచ్చేసి.
I'm removing the
Dr.
whisper wire.
Oh,
I was what here.
we have some suggestion from the room.
Please go ahead.
3.5 తీసుకోండి.
You remove the wire, no?
I removed. I am not interested because I know it's a three-layered stent there, and I may not achieve, and I don't want to spoil the main stent's ISR. That is more important for me.
I think it is a protected
Okay.
PLV. It is a protected PLV like a bypass, protected LAD like protected PLV. So better you have a good stent dilatation with the post-tency balloon 3.5 and
3.5.
having a good TIMI3 flow to PDA.
New bullet.
Okay.
That's what.
Thank you so much.
Thank you. Finally, I sincere thanks to Dr. Tamam, and I dedicate this success of this case to my father, whom I lost recently. Dr. Tamam knows it.
Okay.
So thank you all.
Okay, thank you so much for your kindness and all your team.
Thank you. Thank you. So
Thank you.
much.
Thank you very much, Alex.